Now we're going to move on to disability. What is the patient's level of consciousness? Is the patient somber? Is the patient unresponsive? A lot of times you need to know, number one, what is the patient's cognitive ability prior to this trauma? If you've got family there or people that know this child, you need to know, were they, say you go to a scene of a 3-year-old that's been hit by a car. Was he a normal 3-year-old to begin with? Did he talk? Is he walking? Or has he met the normal milestones for that age group? Does the patient, when you approach him, act appropriate for their age? There is not a 2-year-old that should just let you walk up to them and start cutting their clothes off, strapping them to a board. If they're cooperative, you need to be worried. Okay? Does the patient recognize their family? It's very important to know this. Your family, as far as neurological status, your patient's family, neighbors, people that know these children that you go and get, they are going to be your best resource. Okay? If the patient's mother is with you and they tell you that this patient is not acting right, you need to definitely look into this. This is not something that you should take lightly or just blow off that he's just scared, because they know. We talked about the patient being too calm. 2-year-olds have separation anxiety. If you go to take this patient away from their family members, put them in the back of an ambulance and they just let you, then you need to worry, because that's not appropriate for that age group. Is the patient too agitated? Most children will holler and scream and, but combativeness, you need to look into that as well. We need to look at the pediatric Glasgow Coma Scale. It's a little different than the adult coma scale, because you have spontaneous eye opening. You want to know if they open their eyes to speech, if they open their eyes to pain, or if they don't open their eyes at all. Now, children of all different ages have different verbal responses, so you need to be aware that, the 16-year-old, yes, they should be able to talk to you and should be relatively be able to discuss what hurts. But sometimes when you've got a 5-year-old and they're just kind of crying and they're not really talking to you, that's something you need to worry about. You want to make sure that they're forming their words correctly, making appropriate sounds for their age. And then motor response, you'll note that for the pediatric Glasgow Coma Scale, there's only 14 is the highest, okay, whereas 15 on the adult coma scale. A 2-year-old, you're going to have a little trouble getting them to obey commands. But if they won't do it for their parents or family, then that's when you need to kind of look at it and wonder. And then, of course, flexion, localization, and extension, all of that is the same as with the adult patient. Now, that was pretty quick. So we've already done our primary survey. We've done airway, breathing, circulation, and neurological status. Now we want to talk about the secondary survey. After you have identified life-threatening injuries, you need to do your secondary survey. You need to make sure that you expose this patient. If you cannot see it, you cannot assess it. They have to be exposed, okay? You have to look at your patient from head to toe. You want to get a full set of vitals. That includes a temperature. You want to follow and trend capillary refill, along with your heart rate, respiratory rate, blood pressure, okay, the normal vitals for adults. Capillary refill will tell you about shock very quickly. So that can include that in your vital signs. You want to make sure you keep these patients warm. They do not have the reserve that adult patients have, and when you get them cold, bad things can happen. You want to give comfort measures, and not always medicinal type comfort measures, okay? You want to make sure that you get a history as thorough as you possibly can, because Most pediatric patients under the age of, 8 to 10, they're not going to give you a great history. So you need to get as much of that as you can while you've got the parents there on the scene. And then, of course, inspect the back. Your patient has two sides. Okay? So, as I said, you want to expose the patient. Everybody gets out of their clothes. Okay? You cannot assess it if you cannot see it. People can have hidden injuries. And this is true in adults as well as pediatric patients. You want to make sure, we talked about getting a full set of vitals. If I was going to use any monitor for a patient, I would want a pulse ox, okay? Gives you a lot of information. If you have a good waveform and a good pleth, then you have a good pulse. It gives you your oxygen saturations, but those are not always available. A lot of times you have to do this manually. But like I said, you want to get a full set of vitals, but one set of vitals does very little good. You've got to trend these. Your patient's status will change and can change, and you have to be prepared to notice that when it happens. You want to make sure that you have a good baseline and then trend them. Your pain score. Make sure that you include your pain score. This is what I consider a full set of vitals: oxygen saturation, respiratory rate, heart rate, blood pressure, temperature, pain score, and I'd like to add cap refill to that because we've talked about trending that and watching the patient's circulatory status.